You can
Oh,
start then. Yep.
okay, can everyone hear me? So we'd
Yep.
like to thank everybody who's joining. We see the participants are joining. This is the second annual advanced practice provider webinar that we've had, and we're doing it. These actually all topics were discussed by advanced practitioners who are on a committee. And the goal of this is to just A, bring awareness of the topics that were picked, but B, to remind everybody that there's an in-person session this year in Chicago. It's in the West End, and it's on Friday, September 13th. And for information about the meeting, I think the registration is nominal, and there'll be a whole nother section of talks. That'll be a half-day session on Friday morning, and then in the afternoon you can join the rest of the meeting for debates and other information. So further information on that, if you go to the website, it's the Midwest Vascular Surgical Society, the website, and go under courses, and you'll be able to find the information there. So our first speaker tonight I'd like to introduce is Dr. Stephen Chung. He's currently at the University of Missouri. He's in the Division of Vascular and Endovascular Surgery. He's currently director of the Vascular Lab for the Heart and Vascular Center. He has a lot of experience with the Vascular Lab in terms of running the projects as well as reviewing actual vascular labs. And we wanted to ask one of the topics that a lot of the advanced practice providers are interested in is the vascular lab. And so the title of his talk is Indications, Basic Interpretation, and Follow-up for the Vascular Lab. Dr. Chung, thank you so much.
Hey, thanks for the introduction. So it covers the topic and we'll go through. So let's begin. So no disclosures. Regarding the background, prior to the 1960s, there was no good blood flow to quantify evaluations for narrowing. So back in the 60s and 70s, Dr. Strandis at the University of Washington helped develop the duplex. So what is it? It's a combination of ultrasound imaging using the sound waves to reflect cross-sectional images and combining it with Doppler, so color flow Doppler, as well as spectral waveforms to get information. Everything is based off the Doppler effect. So as sound waves get closer, it becomes higher frequency, and as it goes away, it's low frequency. The machine usually does the mathematical transformations for us to get this information. And the last concept that's relevant would be Bernoulli's principle. So we do know as things get more narrow, the velocities go up, and that's the main principle for what we're looking for. The carotid duplex we'll go over first, just because it's also the first validated study. Indications, screen indications have changed. There's no great screening recommendations for asymptomatic patients, although high-risk patients would consider screening for. So someone with coronary artery disease, peripheral arterial disease, or a history of smoking should get evaluated. Otherwise, patients with a history of TIAs or stroke should be screened, as well as amaurosis fugax or monoocular transient blindness. Otherwise, history of carotid stenosis, history of carotid interventions should be evaluated as well with duplexes. Currently, the main criteria used the SRU. The main numbers we focus on would be numbers greater than 125 centimeters per second to be consistent with greater than 50% blockage, and then greater than 230 centimeters per second would be considered high grade or greater than 70%. There are additional secondary criteria as you can see on the chart, but that's usually what I focus on. So what to do for the patients? Asymptomatic high-grade stenosis should be referred for surgery. Patients who are symptomatic and greater than 50% should be referred for surgery, so history of TIA, strokes, or amaurosis. Otherwise, someone with previous known stenosis but did not meet criteria for surgery, I usually repeat annually. And then someone with a previous surgery, after the surgery, I usually repeat the study at 1 month, then 6 months for 2 years, and annually thereon in just to monitor for restenosis. The ankle brachial index. So this is obtained for patients with claudication or reproducible lower extremity pain with exertion that relieves with rest. Otherwise, we obtain it with patients with wounds in the lower extremity just to see if there's enough blood flow for that to heal. So how it's obtained in interpretation, we get brachial pressures in both arms and then DP and PT pressures in the lower extremity and take the higher of the two arms and the higher of the two legs. For interpretation, every vascular lab is a little bit different, but numbers, ratios greater than 1.3, 1.4 would be considered non-compressible. Anything less than 0.9 is considered abnormal or positive. Each vascular lab is a little bit different in terms of mild, moderate to severe, although most would consider anything less than 0.4 consistent with chronic limb-threatening ischemia. So again, ABIs less than 0.9 or toe brachial index. If the ABIs are not reliable, less than 0.75 is consistent with disease. If someone actually has a normal ABI but pretty typical symptoms of claudication, would consider an exercise ABIs to see if it unmasks a more proximal aortoiliac blockage. Other numbers I look at would be absolute toe pressures less than 30 would be consistent with inadequate blood flow to heal a wound if present. And I usually repeat the ABIs with each clinic visit unless I'm looking for another cause like checks or something like that. Doppler waveforms. So this is additional image information we get from the ABIs. Triphasic is normal, so the positive flow forward plus the reversal flow below the baseline and then the positive flow return. As the vessel gets more diseased, it becomes the biphasic waveform with loss of the third peak. And lastly, when the vessel becomes non-compliant, all there is a positive flow or forward flow with the cardiac contraction. The lower extremity duplex, usually performed when I'm planning for a procedure if no previous interventions as cross-sectional imaging to identify areas of concerns. Otherwise, I perform it afterwards just to monitor for narrowing or recurrent disease. Interpretation, the main area to focus on is here. So anything with a peak systolic velocity greater than 200 or doubling of velocity. So for example, 70 approximately going above 140 would be consistent with greater than 50% stenosis or hemodynamically significant stenosis that may benefit from treatment if planning for treatment. So besides planning for interventions, I usually obtain every 6 months after an open procedure or aortoiliac procedure for inflow disease. Otherwise, for infrainguinal disease, I repeat every 3 months for 1 year, then every 6 months for the second year, and then annually thereon in. Other numbers I worry about would be a peak systolic velocity after a bypass graft less than 45 would be considered threatened. So even if I don't see a narrowing or blockage, I would recommend and perform an angiogram just to look for possible failures. And other reasons they obtain it is if there's concern for occlusion, so they have recurrent symptoms. Axis site issues. So oftentimes after angiograms from either us or cardiology or neurosurgery, there may be problems. One thing we can see from these from these duplexes is something called a pseudoaneurysm or bleeding into the soft tissue. In this situation, we'll see the yin-yang sign on the color flow or the two-furrow waveform as you see here. Depending on how large the pseudoaneurysm is, how symptomatic the patient is, and if there's any superficial changes, they may be amendable to just watching versus ultrasound-guided injection versus open surgery for repair. Something else we can see would be the iatrogenic AV fistula. So in this situation, you can see in the top left, the waveform is what we call low resistance. There's flow in both systole and diastole. So instead of the normal triphasic, biphasic waveform, it suggests that there's basically continuous flow through the entire system. And then higher up, you may just see continuous flow in the vein, as you can see on the bottom right. The aortic duplex. So indications would be anybody who meets screening indications, so 65 and older, smoking history, or a first-degree relative. Otherwise, we obtain it after endovascular repair just to monitor sac size to ensure either resolution or stability. Anything less than 2.5 would be considered normal, 2.5 to 3 ectatic, greater than 3 aneurysmal, and then consider repair if female greater than 5 and 5.5 for males. Follow-up schedules. 3 to 3.9 would repeat every 3 years. 4 to 5 would be annual, and then 5 to 5.5 would be 6-month repeat images for males or plan for surgery in a female. Then post surgery would repeat imaging at 1 month, then 6 months if there's some concerns. Otherwise, recommendations nowadays would be annual follow-up. The mesenteric duplex. Indication would be abdominal pain and concern for chronic mesenteric ischemia. So this would be the postprandial abdominal pain associated with weight loss and food fear. I would not usually get this for acute mesenteric ischemia, usually because there's just too much bowel gas, and so there's not going to be good images. Otherwise, postoperative surveillance would be another reason for it. Interpretations. If patients had previous stents, there are certain numbers we look at. For SMA, it'd be 412 and celiac artery 365. Otherwise, in native disease, which is usually when they're obtained, the numbers we look for greater than 70% narrowing would be 200 in the celiac and 275 for the SMA. And then what to do, someone with symptoms would consider referral for surgery if present, and then post-op surveillance at 1 month, 6 months annually thereon in. Renal artery duplex. Indications usually going to be for uncontrolled hypertension despite 3 medications, or possibly acute renal failure following initiation of an ACE or an ARB, or for post-op surveillance. Regarding interpretation, the numbers we look for this would be greater than 180 centimeters per second, greater than 60% blockage, or renal aortic ratio greater than 3.5 with an aortic number velocity greater than 40 in the juxtarenal position. And then additional numbers we look for would be the resistive index, which is comparison between the systolic and end diastolic flow velocities. And if the difference is greater than 0.8 in terms of ratio, it may not be warranting intervention because it may be considered non-salvageable. And other things we can get from this would be the renal size. If it's less than 7, it may be considered atrophic and not warranting intervention. So for follow-up, uncontrolled hypertension or symptoms, consider interventions, and then for post-op, 1 month, 6 months, and annually thereon in. The venous duplex. So usually obtained in situations where would be concerned for a DVT, so leg swelling, pain, or cyanosis, or for evaluating for venous insufficiency, so medial malleolar wounds or varicose veins, or in the setting of vein mapping for either a CABG or lower extremity bypass, or for dialysis access. What we look for DVTs is number one, a non-compressible vein, but also enlarged compared to the artery. And then with regards to the reflux, we're looking for blood flow, number one, going the wrong direction, and usually reflux lasting for X amount of time. So in the larger deep veins, it'd be 1 second. And for the smaller superficial veins, it'd be 0.5 seconds or 500 milliseconds. And in this case, it's the saphenofemoral junction, and it's 5 seconds going the wrong direction. And then lastly, for dialysis access, we obtain it to determine maturation for access creation or evaluate for sources of malfunction. So patients with prolonged bleeding, pressure alarms, or pseudoaneurysms would obtain it. So the rule of sixes we learn during fellowships. So it has to be at least 6 millimeter in size with at least 600 milliliters per minute of flow through it and accessible to be less than 6 millimeter from the skin level to be at least adequate for maturation and use. Afterwards, we look to see the AV anastomosis. If the velocity triples will be concerning, or if anywhere along the outflow with a doubling of velocity will be concerning and may require intervention. So any questions?
Yeah, if you have any questions, make sure you put them in the question section. It's called question and answer. So from the people who are on the webinar, are there any questions? One question they said here would be possible to get a copy of the presenter's slides after the webinar. It'd be nice to review the info once again. So I guess Angela can help us with that, and we can certainly get those slides available on the website. And so once again, we're pushing remember that Friday, September 13th, the Midwest Vascular is going to have an in-person meeting. I think, Steve, one of the questions I have actually is, sometimes I think that for the advanced practice providers that, other than surveillance, they want to know, which test do I get when, right? And so I know that sounds basic, but sometimes, so for example, after a lower extremity bypass, would you push for a duplex or ABIs? And actually even varies in our practice, right? Or even after an SFA intervention like a stent, so those are some of the things I think is like, because think about the APPs are seeing them pre, but maybe post-op for discharge, right? So what will be your surveillance in terms of, like, for example, a lower extremity stent be versus a bypass? And, how soon would you see them back, and what would you do? I'm just curious, because I think that's one of when we had our seminar, our meeting for the seminar, that was one of the was things is when do I order what and after what, So for that seems like a story. So you do an SFA like a FEMPOT bypass versus an SFA stent.
So I think we're all a little bit different. How I do it, I think we all see patients at least 1 month afterwards with a baseline ABIs and lower extremity duplex. Then afterwards, what I like to do is see them every 3 months. If it was an SFA stent or any intracranial endovascular repair, I like to watch every 3 months just to see if there's any recurrent disease at that point.
With ABIs, or you follow with ABIs, or you do?
With ABIs as well as duplex. So if there's any failures, either with drop in ABIs less than 0.15, or if there's doubling velocities on the duplex, and oftentimes I feel like the duplex is a little bit more sensitive. I did read
Right.
one of the recommendations now for a vein bypass would be at 3 months versus a PTFE bypass. It's 6 months. So it'd be
Oh,
one
really?
more.
They've delineated a difference now? I know.
Yeah.
I find actually, because even in our group, we're very different. I find after an SFA intervention, if it's a stent, I usually get a baseline ABI, right? And
Mhm.
then at 3 months, I get an ABI and a duplex. And then I almost, and if everything looks good at 3 months, I actually march out 6 months, and then I continue on the stents for 6 months, right? I catch a lot of in-stent stenosis, and you never catch it on ABI.
Yeah.
So, and then I think that's the same for the bypasses. So they're saying for a PTFE bypass, you would do a 6 month duplex, and
Yeah.
then
One
what?
month, 6 months, and 6 months, and then annually.
Yeah.
But then for vein, apparently now they made a distinction where vein bypass should get a 3 month as well interval.
Huh. Oh, so it'd be 1 month, 3 months, 6 months, 1 year, and then if it looks good every year.
Yeah.
Yeah, I think that makes sense because once the bypasses are working, it's you have a lower chance of certainly within the first couple of years for insular hyperplasia. But I find the stents, because we all know the stent patency,
Mhm.
over 2 years is what for an SFA straightforward sometimes can be as low as 50%, right? Over 2 years the patency. So I find the stents I really. How about for another thing actually is a T-car versus a carotid. Like so I'm discharging your patients. I'm being our Tiffany, who's our
Mhm.
outstanding nurse practitioner. But do you do anything different for a T-car versus? I know she knows all of our individual things, but what do you do for a T-car versus a carotid?
So in training, we actually for TCAR, it was every 3 months. But when I reviewed the criteria most recently, the open CEA and the endovascular seems to be every 6 months after for the first 2 years. It's the same. So.
Yeah, I know it's funny. I almost always do a 1 month follow up with a duplex, so I know what our new baseline is, and if it's at all elevated, I worry about hypoplasia. I'll see them in 3 months,
Mhm.
and then in 6 months with a duplex. And same and the T car, even though the velocity criteria are different, right? But I don't screen them as much. But I think we should think about it because that's one of the big issues. For 2 years, and after 2 years, I feel comfortable going annually. But before that, I was worried about hypoplasia or something else. So.
Mhm.
That was a great talk. Thank you very much, Dr. Chung. Appreciate it. And so we keep us on time. We're going to move forward. Our next presenter is Eric Woodhouse, who I've had the pleasure of meeting virtually multiple times, hopefully actually in person. He'll be speaking as well at the meeting, which is September 13th and Friday in Chicago. Information is on the MVSS website. He is currently a nurse practitioner in the Division of Vascular Surgery at the University of Wisconsin Medical School and the Public Health School at Madison, Wisconsin. His topic today will be common postoperative complications after carotid endarterectomy. And you're on speaker, and you're also on mute. Eric, you're on mute.
All right, sorry about that.
Very good, thanks.
All right. How's this look? Everybody can see this?
Yeah, but it's not full screen like you had it before.
Anybody know how I do that? Sorry, guys. I know how frustrating these are.
How did you do it before? Do you remember?
No. I mean, I did the same thing. Well, let me try this. How about now?
I don't see anything actually right now. Angela? I guess you have to hit share. Did you hit the share on the bottom?
Yeah.
There, that's good. Perfect.
Oh, there. Okay. Sorry about that,
Excellent. All
guys.
right, thanks.
I know how frustrating these technical challenges can be. Um, thanks for the introduction, Todd. I have been a nurse practitioner with UW-Madison for about 5 years now, and I'm really excited about this APP initiative. I actually had the opportunity to present at the MVSS conference in 2022 in Grand Rapids, and it was a great experience. But I was kind of keenly aware that I was the only APP presenter, and so this initiative is awesome, and I'm glad I can do something to support it. So when doing my research, I frequently came across this quote, which is, "Few vascular operations are as well tolerated as a properly performed carotid endarterectomy." And I thought this was applicable here. But, it's important to understand, even with perfect technique, complications still arise. And so I tried to kind of put these slides together in order of, when these things typically occur. And so starting in the PACU, I want to start with cervical hematoma. And so the incidence of carotid hematoma in the literature is between 1.2 and 12%. It seems like a high number, but this also reflects the hematomas that did not require surgical intervention. A cervical hematoma can be catastrophic and result in the abrupt loss of an airway, and this typically occurs in the early stage. When discussing, cervical hematomas, we have to consider kind of superficial versus deep. And so, a superficial hematoma is typically above the platysma. And these actually look, in appearance, very severe. They're ecchymotic and there's kind of bulging under the incision. But, these patients can also sometimes be asymptomatic. But what's more worrisome is a deep hematoma, which occurs kind of below the platysma. And it can go kind of unnoticed for a long time, which is far worse. There are several risk factors for cervical hematoma, and these can be grouped into preoperative, perioperative, and postoperative. So in the preoperative setting, antiplatelet and anticoagulation therapy, is important. You need to know, when they took their last Plavix or aspirin. You also want to know their platelet count, as we know thrombocytopenia can lead to a hemorrhage. And then in the operating room, the factors here are the operator, neurologic alterations during surgery, was a shunt used, surgical technique, protamine use, and the mean arterial pressure. And then in the postoperative setting, what's paramount is blood pressure control, and then also postoperative coagulation, which, at least in my experience, is more of a rarity. In these images here, this is a 55-year-old man who underwent a right carotid endarterectomy. And so the figure in figure A, this was taken in pre-op, and you see this is a pretty normal X-ray with the trachea midline. And then in picture B, this is post-op day 1, and shortly after the patient started to experience dyspnea. And you can see with the white arrow here that the trachea is deviated to the left. And then the image in C is status post-intubation, and you can see that the trachea has returned to midline. So starting with the bedside assessment of these patients, respiratory is paramount. We're evaluating for hoarseness, stridor, dyspnea, tachypnea, subtle changes in voice quality, dysphagia, and then I think tracheal deviation is more of a late sign. But, if a patient truly has any of these symptoms below, agitation, anxiety, confusion, wheezing, or gasping, these are all signs of impending respiratory failure. And in this case, you really do have a true emergency on your hands. And so in the management, obviously we want to put these patients on high flow oxygen. I can't advocate enough, that the PA or NP really needs to stay, at the bedside with this patient because this is an emergency. If there's been one consistency across the literature that I've read, it's that, when a patient loses an airway in this situation, it can happen very rapidly. And so in this situation, you're going to have your nurses bring the crash cart into the room, stat page anesthesia. You need to notify your surgeon immediately because the overall goal here is to get the patient to the OR as quickly as possible. And then what's important in this scenario is that, if respiratory arrest is impending and the patient is not yet intubated, you may need to open at the bedside. And I get it. This is quite a scary situation to be in. But, in this particular situation, the PA or the NP may really be kind of the factor between life and death for this patient. And so how you would do this is you're essentially going to quickly prep the neck with your betadine or iodine, and you're going to use sterile scissors to cut the superficial and the deeper layers of sutures and manually evacuate the hematoma. Another common thing that often comes up in the PACU setting is a cranial nerve injury. Cranial nerve dysfunction is the most common neurologic complication after carotid endarterectomy. Approximately 5% of our patients will experience a nerve injury, though less than 0.5% of patients will have permanent injury. And these statistics really vary, kind of depending on the research method used, retrospective versus prospective. But, most of these injuries are asymptomatic and mild in severity and resolve within 1 to 2 months. I've included this, image on the right, at least for myself. You kind of get clarity of this complication when you see exactly kind of the anatomic location of the nerves and where they lie in relation to the carotid artery. And so most deficits are due to blunt injury during dissection, stretch trauma from excessive retraction, and electrocautery injury. Nerve injury is much more likely when reoperating because of excessive scar tissue. And then the nerves at potential risk for injury are the facial nerve, the glossopharyngeal, the vagus, the accessory, and the hypoglossal. And so in this chart on the right, it lists the incidence of nerve injury, and you can see that the hypoglossal is the most common, which makes sense given its proximity to the bifurcation and where it lies in relation to the carotid body. And the least frequent is injury of the spinal accessory nerve. So, given kind of the time I've been allotted in this presentation, I'm not going to go through every nerve, but I've listed them all here, for reference, afterwards. But, given that this is an APP kind of directed presentation, I do want to talk about kind of the 3 most common things that we see, at least for myself, like as a nurse practitioner. And the first thing is, the patients who have slight symptoms, it's the, mild dysphagia. They have a tickle in their throat or a sore throat. And then you're always kind of wondering, is this a nerve injury or is this, an intubation complication? We know the complications of intubation can be, vocal cord injury, aspiration, and soft tissue injury. And so, you really need to read the anesthesia report, and, you can always page the anesthesiologist. And, if you're more concerned and have questions about, how they were intubated and the symptoms that they're having, you should do this. And then, patients after carotid endarterectomy that have a nerve injury, are at high risk for aspiration. And so, I wouldn't hesitate to, get a swallow study on these patients. But I think more importantly, is that, in this setting, I say difficult, but I mean, it's more impossible actually to differentiate a cranial nerve injury from a stroke. And so the diagnosis, of a nerve injury can be made only after you've ruled out a stroke. And then treatment for nerve injuries, it's largely supportive, though severe nerve dysfunction may require further intervention. And in the most severe cases, patients can require tracheostomy or even a feeding tube, which is a devastating complication. And then importantly, even with, gentle technique, gentle retraction, some patients still end up with a nerve injury. And probably most common, or, what I'm called to the PACU for is the patient with ipsilateral kind of lower lip droop. And in your mind, that this may likely be, an injury to the mandibular branch. But again, until you rule out a stroke, it's not. Another common complication is a headache. And so, after surgery, a headache is not unusual, but it does always warrant further investigation. So for most patients, the headache runs a self-limiting course, and it's probably related to temporary altered autoregulation dysfunction of cerebral circulation. And the headache etiology may be multifactorial. It usually always is. I've listed kind of the most common things here, but this is by no means a totally inclusive list. So, when you're seeing these patients, or when I get called about, a fresh post-op, carotid, like with a headache, one of the first questions I always want to know is what their blood pressure is. It's difficult to assess a headache in this patient, if they're severely hypertensive with a, systolic over 200. And then you really need to take a good medical history, from your patient. Do they have a history of migraines, or cluster headaches or tension headaches? Is it ipsilateral? Is it frontal? Is it posterior, global or focal? These are all important answers that are going to kind of guide your treatment. And then you want to ask about the severity. And, for most patients, as long as their blood pressure is in, target range, then we'd usually begin with Tylenol. But if you give the patient Tylenol, whoops. If you give the patient Tylenol and, there's relatively no change in the headache, or if it actually gets worse, then hyperperfusion syndrome should really be kind of on the high on your list of differentials for these patients. Luckily, this is a very uncommon complication. It occurs an estimated 0.4 to 1.8% of patients, but the mortality is very, very high. It can be up to 66%, and this is a devastating complication for these patients that can lead to death. And this is also, the most common cause of intracranial hemorrhage and seizures for the first 2 weeks after surgery. And so I think in our context, it's important to know, for the routine patient who goes home on post-op day 1, they're not out of the woods for hyperperfusion syndrome, and this is something that, when they're seen back, in clinic, by our APPs, we really need to, ask about these symptoms. And the mechanism here is that, the distal collaterals are chronically dilated due to the stenosis. And then once you, suddenly improve the perfusion, it's thought that these vessels that have been maximally dilated for so long are unable to vasoconstrict. And then what you result is hyperperfusion to that cerebral side of the brain. And so the best management is prevention. And that's with, strict blood pressure parameters. And, for most of us, this is probably a systolic of, 100 to 150. But, we also know that, after manipulation of the baroreceptors during surgery, these patients can have blood pressure lability that typically resolves in 24 hours. And one recommendation that I have is to always have your, blood pressure agent of choice, whether it's a beta blocker or a calcium channel blocker, in line when they come out of the OR. Because I've seen this happen before where, the patient is, normotensive coming out of the OR, might be normotensive in PACU, but then they, get to their room or up on the ward, and suddenly, they have a blood pressure of 200, and that's not the time to be ordering your nicardipine or your labetalol. You'll be waiting for, who knows, 30 minutes maybe between pharmacy and nursing. So if you already have it in line, then it's just a simple on. And then any patient who complains of a severe headache or the worst headache of their life after carotid should have a head CT performed. So the clinical features of hyperperfusion syndrome, it's a headache. It's ipsilateral to the revascularized internal carotid artery, and it's typically improved with sitting the patient upright. These patients can have focal motor seizures, sometimes with post-ictal paralysis mimicking a stroke. And then the most dreaded complication for these patients is an intracerebral hemorrhage, which occurs in 0.5% of patients after carotid. So stroke is the most feared complication of carotid revascularization that limits the benefit of the procedure and overall stroke prevention. And then stroke is the second common most cause of death after endarterectomy. And this is second to MI. I think upwards or up 40 to 50% of deaths are related to myocardial infarction. And roughly 40% of patients who have carotid artery stenosis also have symptomatic CAD. And so it really highlights the importance of our preoperative cardiology workup, which may include stress testing and possibly PCI. So in experienced hands, they say that this occurs between 1% and 3%, depending on the indication for the procedure. But I've also read, like in other reports, the risk may be as high as 3% for asymptomatic and 5% for symptomatic patients. And then the patients who are at the highest risk of stroke are, reoperations on patients with recurrent carotid artery stenosis.
Great. I think we're going to have you stop there so we stay on time. That's really fantastic. We actually had one question from the audience that says, why does shunt use increase the risk of hematoma? Is it shunt specific?
Yeah, that's a great question. And so from what I've read, I mean, you guys can probably speak more to this, but if you are competent in your use of a shunt, I think it decreases the risk. However, there can be errors shunting, I think, in the newly trained person, which can lead to stroke. That's my understanding.
Yeah, no, I think for the shunt, I think everyone has their own. Some people are selective shunters and some people shunt all the time, right? So the reason why you shunt is because you're worried you won't have adequate cerebral flow while you clamp the carotid, right? So you clamp the carotid and you're worried you're going to have an ischemic event. But the reality is, if you look at the statistics, the number of patients that actually have cerebral ischemia is relatively low. It's probably 10%. In our experience, it's 10% less. And I think the reason is because the patients have got collaterals either from the vertebral arteries, two vertebral arteries, or the contralateral carotid through the circle of Willis. So I think that so we do selective shunting where all the patients, when they get their carotids, have EEG monitoring. And if we notice there's a change in the EEG demonstrating that there's ischemia, we then do a selective shunt and shunt put in. And so sometimes people would argue, well, you don't shunt that often, so it'll be even harder. I do think there can be technical problems with the shunt. I think probably the most common problem with putting a shunt in is the dissection, right? So if you're too aggressive, whatever type shunt you have, there's about three. There's a Pruitt and a Haar, which is what I like. Some people actually use very small. There's a Javits shunt. Is a dissection, right? Because when you put the shunt in the distal internal carotid, you always where you're going to hit because actually as the carotid goes up towards the base of the skull, it curves to see where you'll have the dissection. So I'm not aware of anything that increases the risk of hematoma, but it can increase the risk of stroke. Plus, you have to realize when we do selective shunting, you already demonstrated your increase of stroke because you've had ischemic changes. So I don't know, but I think that everyone has to have some people do stump pressures, which we don't do. But I do think there are technical parts for shunt, but if you do it more regularly, you're probably less likely to have a technical problem. Thank you so much. Just to keep us on time, we're very fortunate to have a very good friend of Dr. Milner's now with us tonight, Dr. Sandeep Nathan. He's currently from the University of Chicago Medicine, Heart and Vascular Center. He's the medical director of the Cardiac Intensive Care Unit. He's the director of the Interventional Cardiology Fellowship Program and the co-director of the Cardiac Catheterization Laboratory. And in the APP discussion, we really one of the things a lot of that I think that they do more than we do is a lot of the medical management after. So his topic tonight is contemporary antiplatelet therapies, and he'll also be speaking in person. Very excited in Chicago, which was I can't push it enough. Is September 13th and Friday in Chicago. So make sure you come. Thank you so much, Dr. Nathan.
Well, thanks so much for for having me, Todd. Really appreciate it. Big thanks to you and Ross for the opportunity to speak, both today as well as live in Chicago. Okay, so in the next 10 minutes or so, I'm going to cover contemporary antiplatelet therapies, and this is honestly there's enough material here to go on for an entire symposium. I'm going to try to abbreviate it into just the things that that matter, in my opinion. Here are my disclosures, none of them relevant to this talk. Okay, so here's the epidemiology of cardiovascular disease. Cardiovascular disease is, in fact, on the rise in the United States and in many different sectors of the spectrum. About 18 million adults have CAD, and that number is growing with an aging population. Somebody in the United States is having a heart attack every 40 seconds. And so it's in the rearview mirror for a lot of patients who are undergoing vascular surgery and every kind of surgery. The factors associated with increased risk of recurrent CV events in CVD patients are shown here. The severity of disease, a prior cardiovascular history, particularly if they have polyvascular disease, multiple beds that are affected, patient characteristics and various comorbidities that we're all too familiar with enhance the risk of future events. And so these are the patients that we should really be caring for carefully in terms of their perioperative and postoperative medical management. And for many of these groups, antiplatelet therapy serves as cornerstone therapy. There's some similarities and some differences between arterial and venous thromboses. These are, of course, the kind of events that we're trying to prevent with antiplatelet and anticoagulant therapy. I can just sort of simplify this by saying that there's very little data to suggest that antiplatelet therapy improves venous thrombosis. Now, in conjunction with oral anticoagulation, perhaps, but very little data to suggest that antiplatelet therapy meaningfully impacts venous thrombosis events. On the other hand, arterial events, which are triggered by high shear flow at the site of plaque rupture or disruption with a sort of a predominant activity of platelet-rich thrombi, are certainly preventable with antiplatelet therapy. That's where we really kind of focus our efforts. The coagulation and platelet cascades in cardiovascular disease is simplified on this slide, the coagulation cascade on the left and platelet activation sequence on the right. You'll notice that one key crossover is the generation of thrombin. So prothrombin is cleaved to thrombin. Thrombin serves as the most potent endogenous activator for platelets. And similarly, there's sort of this bidirectional relationship back from the platelets to a coagulation cascade because the surface of the activated platelet serves as one of the platforms for assembly of the prothrombinase complex. So there is this bidirectional relationship, and one may speculate that perhaps inhibiting platelets may improve or reduce the formation of clot via soluble coagulation proteins. But most of the activity on the right side of the slide is in with regards to reducing arterial events. If you sort of pan out of the shot, though, there's about 200 endogenous activators for platelets. And really, we've just sort of scratched the surface in terms of the therapeutic agents that can inhibit platelets safely. And safely becomes a key word here because, there's many ways to inhibit platelets or shut down hemostasis altogether. But as every APP and surgeon on this call knows, shutting down the platelets completely or inhibiting coagulation proteins results in potentially life-threatening bleeding. And so highlighted on this slide are some of the key classes of agents that we use for inhibiting platelets in a therapeutic fashion, including inhibition of COX-1 by low-dose aspirin, clopidogrel, prasugrel, ticagrelor, and cangrelor for the P2Y12 inhibitor. Vorapaxar, which is sort of off the market right now, was the first in class of the thrombin receptor antagonist, and then, of course, glycoprotein inhibitors for shutting down the final common pathway for platelet aggregation. So a lot of the focus has been for the past couple of decades on the ADP P2Y12 receptor. This is a prime target for therapeutic modulation because it doesn't just sort of impact one receptor, it impacts multiple receptors that are responsible for platelet aggregation. And I'll get into the agents that you're all familiar with in some capacity, but this is sort of a gateway, if you will, for platelet activation, degranulation of various granules within the platelet that then result in platelet aggregation. There's a lot of detail on this slide. I'm happy to share my slides, so if you want to peruse this at your leisure, you're more than welcome to. Dr. Vogel, I'll send a PDF of this presentation to you for distribution. But here are the here's the comparative pharmacology of all of the oral antiplatelet agents, starting with aspirin, clopidogrel as the P2Y12 receptor that I think receptor antagonist that everyone is most familiar with, prasugrel, ticagrelor, and then vorapaxar. Just understand that ticagrelor, among the commonly used agents, is the only orally active antiplatelet agent. So as it's ingested, it's actually used at the level of the platelet. The other agents all need to undergo first pass metabolism. They work at different sites in the cascade. When quiescent platelets become activated platelets, that's potentially preventable with aspirin, ticlopidine, clopidogrel, prasugrel, ticagrelor, and cangrelor. The activated platelet, once you already have arterial thrombus, it's very difficult to get rid of it without mechanical disruption and the use of glycoprotein inhibitors. And that's sort of where we use this in the cath lab for acute myocardial infarction or arterial thrombosis with a large clot burden. Summarizing decades worth of aspirin data, aspirin in the secondary prevention of cardiovascular events is very effective. How effective? About 20 to 25% reduction in events in multiple trials. This is from the Antithrombotic Trialist Collaboration meta-analysis. Clopidogrel plus aspirin versus aspirin alone in high-risk patients. This is data from CURE, about a 20% relative risk reduction in events. And these are all patients who had either unstable angina or acute coronary syndromes, non-STEMI, and so forth. When prasugrel, representing a more potent P2Y12 inhibitor, still thienopyridine, hit the market, it was on the basis of this trial, Triton-TIMI 38 versus clopidogrel. Prasugrel was even more effective at reducing events. It's a more potent antiplatelet agent, but there was an increase in major bleeding in prasugrel-treated patients versus clopidogrel-treated patients. And then when ticagrelor came out, it was on the basis of the Plato trial shown here, about a 16% relative risk reduction in cardiovascular death, myocardial infarction, or stroke. So summarizing the last couple of slides, aspirin is better than placebo in the long-term secondary prevention of cardiovascular events. Dual antiplatelet therapy with clopidogrel aspirin more effective than aspirin alone in high-risk patients, and either of the potent P2Y12 inhibitors, that is prasugrel or ticagrelor, even more effective than aspirin clopidogrel in reducing events, but there is a small creep in terms of major bleeding. When we think about inhibiting platelets quickly, the potent P2Y12 inhibitors, particularly ticagrelor, because, as I said, it is an orally active agent. It's not a prodrug. It's a drug that works immediately on the platelets, is more effective than clopidogrel. So even with a 600 milligram loading dose, you can see a much flatter slope to reaching therapeutic platelet inhibition at about 40 to 45% inhibition versus 80 to 90% with an 180 milligram loading dose of ticagrelor. And similarly, I think this is very relevant for surgeons and for surgical practitioners. Very importantly, the offset of ticagrelor, being a reversible agent, is quite rapid. And so within 1 day after your last dose of ticagrelor, you've already dropped to what would be therapeutic for clopidogrel, and you could see this curvilinear decay in platelet inhibition. So within about 3 days, you're basically at 20% platelet inhibition. And while the recommendations stand that you should wait 5 to 7 days, there's not a whole lot more to be gained between day 3 and day 7, as you can see on this plot. So what have we achieved with oral antiplatelet therapy in 40 plus years of antiplatelet trials? Placebo to aspirin monotherapy, 22% relative risk reduction in cardiovascular events. Aspirin monotherapy to dual antiplatelet therapy, or DAPT, with aspirin clopidogrel, another 20% reduction in high-risk patients. aspirin and clopidogrel to dual antiplatelet therapy with potent P2Y12 inhibitors, a further reduction of 16 to 19%. But all the while, there has been this sort of slow increase in major bleeding as we get to more and more potent agents. And the unfortunate reality is that thrombosis and hemostasis are two sides of the same coin. And the problems of thrombosis and hemostasis often coexist in the very same patient. So we like to dichotomize this as bad clot when, clot forms in a vessel supplying a vital organ. That's bad clot. But good clot prevents bleeding. Unfortunately, what you're seeing on the right side of the slide is an 8-gram retroperitoneal bleed in a patient who came in with an acute myocardial infarction with an RCA that was totally occluded, received a balloon pump, and the patient clotted and bled to death at the same time, unfortunately. So, this is sort of the double-edged sword of antiplatelet and anticoagulant therapy for that matter. The parenteral agents, two classes that you should be familiar with, the platelet glycoprotein inhibitors, or GPIs. Abciximab is now off the market. That was the prototypic agent. It was a chimeric monoclonal antibody, very potent, and stuck to the platelets for several days, up to 2 weeks after the infusion. Tirofiban and eptifibatide are still on the market. These are synthetic agents that have a half-life of about 2.5 hours. Cangrelor is, I think, a really important agent for everyone to be familiar with because it has value both in therapeutic inhibition as well as part of a bridging strategy in patients who need to have an operation while they're still on oral dual antiplatelet therapy. So for large vascular procedures or other solid organ operations where bleeding isn't well tolerated, Cangrelor has been a true boon for bridging these patients through the procedure. It's a modified ATP derivative that is, you can think of it as the IV version of ticagrelor. It is very rapid onset. Within about 10 minutes, you've got complete platelet inhibition. Within 1 hour, you have restoration of normal platelet function. This has been very clearly demonstrated in the appropriately named Bridge trial that was published in JAMA a number of years ago, where patients went for CABG within about an hour, as soon as an hour after cessation of Cangrelor. In our world, the Cangrelor clinical trial program has nicely demonstrated a reduction in thrombotic events compared to clopidogrel, and in a pooled analysis of 25,000 patients, there was a pretty substantial reduction in stent thrombosis, 41% reduction in stent thrombosis. The benefit was sustained out to 30 days with no increase in severe bleeding or transfusions because this is such a rapidly reversible agent. The last thing I'll cover in the last 2 minutes or so here is deciding on duration of DAP. This often, is a question that's posed to us. How long do we want to continue dual antiplatelet therapy? Well, we've got the DAP score. This is what I use most often in clinic for calculating the risk of discontinuation of dual antiplatelet therapy. And the wonderful thing about the DAP score is that it's not a graded relationship. If you just plug in these very easily discernible patient characteristics into the DAP score calculator, you get a score. And if your score is 2 or greater, you continue DAPT. And if it's less than 2, meaning 1 or less, you discontinue DAPT. And the number needed to treat versus the number needed to harm just flips at a DAP score of 2. It wouldn't be helpful if it was a graded score where slowly these risks change, but at 2, there seems to be a sharp inflection point where you can say confidently that, well, now your DAP score has dropped to 1, you can stop your dual antiplatelet therapy. The very last thing I'll touch upon is the interface between oral antiplatelets and oral anticoagulants. There's a lot of patients in our world and in your world who need both, who need antiplatelet as well as anticoagulant therapy. If you just think about the non-valvular atrial fibrillation population, leaving aside the folks who have DVTs, LV thrombi, you want to keep their grafts open, what have you. There's so many different combinations of dual antiplatelet therapy or antiplatelet monotherapy plus a vitamin K antagonist or a DOAC. Again, I'll share these slides with you, and you can study this in detail if you wish. It took me a long time to put this slide together, but this is the most recent roundup of the clinical trial data to support these various combinations of antiplatelet and anticoagulant therapy. So the summary and key takeaways: oral antiplatelet therapy remains a cornerstone of cardiovascular disease reduction in the secondary reduction population and following vascular stenting. Aspirin monotherapy is effective in most patients with established cardiac or vascular disease. Aspirin monotherapy in primary prevention remains controversial. In the interest of brevity, I didn't really cover that, but suffice it to say that we don't really use aspirin monotherapy that much anymore for primary prevention. DAPT is appropriate for 1 year post ACS and STEMI, irrespective of coronary revascularization. DAPT is required for a minimum of 1 to 3 months post DES, and that's a relatively recent shift. We're running DAPT for 1 month in patients who are high bleeding risk or require an urgent operation, even after drug-eluting stents. DAPT scores a very useful metric for deciding length of therapy in clinic. And then finally, P2Y12 monotherapy is completely acceptable in high bleeding risk patients, even immediately following stenting. Many patients after coronary stenting, I'll send home on just monotherapy, dropping the aspirin, and there's quite a bit of data to support that recommendation. I'll stop there. Thank you again for the opportunity and for your attention.
Awesome. Thank you so much. You know, one of the questions that the fellows always ask is, so what, and it really, I don't think there's a, I don't know, you probably give us your thoughts. We put in SFA stent, you know, right? And so we just did one today, and they're like, oh, you know, they're not on, right? So do you load them or not? How much do you load them? I know that cardiologists usually load like 300 or even 600, right? Sometimes for Plavix.
Right.
And the question is, should they be on aspirin Plavix? Should they be, so what would be your recommendation for the most common, you know, stent we do, which is the TCARs have to be on dual antiplatelet before we even do it. But for an SFA stent, we put in a superior stent, what would your recommendations be and how long?
Yeah. So it's a great question. I mean, I think that you could get a whole variety of answers there. I think that 600 is the correct loading dose for clopidogrel, and it's interesting. Sanofi ran a 25,000 patient trial to get that label change, and the label change actually was on the basis of a 40-something patient crossover study that demonstrated, 300 versus 600. There was no overshoot; it just got you there quicker and in a more predictable fashion. So, if you got 40% platelet inhibition, ADP stimulated platelet inhibition with 300, it's not like you got 80%. You just got to 40% quicker within 2 hours rather than 6 to 24 hours. So I think 600 is the preferred dose for most vascular stents. I think for medical management, 300 is just fine because there's no real burning need to get to therapeutic platelet inhibition within 6 hours. Aspirin, I think, in most indications is rapidly establishing itself as a legacy drug. I think we sort of cling to it because we've always done it, but the data in contemporary vascular or coronary intervention is pretty scant for the use of aspirin. The caveat to this is that in our population here, about 40% of patients do not post a therapeutic response to clopidogrel. So we actually looked at this post-drug-eluting stent implantation. 42% of our admittedly higher risk patients, ACS, STEMI, enriched for ethnic minorities, all predictors for clopidogrel hypo-response, have no response to clopidogrel that you could consider to be therapeutic. So it is a bit of a coin flip if you're using clopidogrel. What proportion is going to respond? Nationally, that number is about 30%. 25 to 30% of patients do not respond to clopidogrel. So, I would say that if their patients are high bleeding risk, clopidogrel monotherapy is fine. In all of our clopidogrel monotherapy patients, we tend to check P2Y12 platelet reactivity. It's a simple whole blood assay, used to be manufactured by Acumetrix. Another company took it over. Our core lab runs it. Costs about $35 for the lab, and there's no sample prep. And if you've got platelet reactivity that's below 200, you know that you're posting a therapeutic platelet response to clopidogrel. And you could feel good about just clopidogrel monotherapy. On the other hand, if you've got platelet reactivity that's in the 300 or higher, you know that you have no therapeutic response to clopidogrel. So there, if you're relegating antiplatelet therapy to clopidogrel monotherapy, you've got nothing at that point. So, we're much more in the camp of using potent P2Y12 inhibitors, but then, we're dealing with patients who've had recent ACS or STEMI.
Great. Thank you so much for joining us, and we'll see you in Chicago.
Sounds
Last
good.
but not least, I get the pleasure to introduce Dr. Luis Sanchez. He's the chief of the section of vascular surgery at Barnes-Jewish Hospital. He's also the Gregorio Sicard Distinguished Professor of Surgery and Radiology. He is the co-director of Barnes-Jewish Hospital Heart and Vascular Center. And his title of his talk today, so when we had our survey, they were talking about Barostim, and I heard he gave a great talk recently. So we're very excited to hear his talk on surgical experience and long-term results. Oh, you have it here. Implantable carotid sinus stimulator for heart failure management. Thank you so much, Dr. Sanchez.
Thank you for the opportunity. I think you can see the slides a little bit better now.
You know, they're not on full. It's on viewer. It's not a full screen.
It's not on full screen.
No,
Here, let's
wow.
swap it. What about now?
Oh, that's good. Perfect.
That's better.
Thank
All
you.
right. Well, thank you for the opportunity to participate and to talk a little bit about this topic that seems to be growing in interest around the country. I have no disclosures related to this specific topic. Heart failure, as we all know, is a challenging problem to be able to manage in our patient populations, and we're seeing more and more patients with heart failure. The initial therapy for patients with heart failure is guideline-directed medical therapy, which works reasonably well, especially initially, for many other patients with heart failure. But many of them, after repeated hospitalizations, progress and don't respond as well to medical therapy and may need a variety of other interventions, including the use of a variety of devices, ICDs, CRT, which is cardiac resynchronization therapies, and other modalities like the one that I'm going to discuss, the use of Barostim or carotid sinus stimulation. On patients that have much more advanced heart failure, obviously you need to start considering some of the advanced interventions, including the possibility of using LVADs and even heart transplants. So if we look at the appropriate medical therapy, these patients do reasonably well with improved morbidity and mortality. And it is suggested that they have 1.4 to 6.3 years of estimated aggregate mortality benefit when comprehensive quadruple therapy is used in these patients with heart failure with reduced ejection fraction. We'll probably concentrate on that patient population. This medical therapy clearly produces modest improvement in quality of life for these patients if it's used as the only therapy. And it also produces modest improvements in exercise capacity when it's used alone and not in combination with other therapies. One of the biggest issues in this patient population is that a large proportion of patients with heart failure over time remain on their target doses, often related to the associated complications with each one of the medications. And many of these patients have discontinued one or more of the medications that are used in combination at 1 year after they have been started in multiple medication therapy. So we have to start considering other options for the management of the heart failure symptoms. The next step that has been developed is CRT therapy, or cardiac resynchronization therapy, which has been available since 2002. But unfortunately, this is applicable to only around 30% of patients with heart failure with reduced ejection fraction. We still have a significant number of patients with symptomatic heart failure that don't have great options to control their symptoms and have a reasonable quality of life. So as we look at other options, the autonomic nervous system has been considered as a potential target. And you heard a little bit about carotid disease earlier in these presentations. And the baroreceptors that sit at the carotid bifurcation modulate the autonomic nervous system, which also regulates the cardiovascular system. This reflex does not work very well in patients with heart failure, and they have decreased baroreceptor signaling that leads to an imbalance in the autonomic nervous system and ultimately dysregulation of the cardiovascular system. So can we manage this and improve the symptoms on these patients by addressing their baroreflex at the carotid location? Decreased baroreceptor signaling results in an imbalance in the autonomic nervous system and an increase in heart failure symptoms, specifically by increased sympathetic tone and decreased parasympathetic tone. The Barostim system, which is a carotid sinus stimulation system, is basically a pacemaker with an implantable pulse generator. And nowadays, as it has changed in generations, has a single carotid lead that can be implanted at the carotid bifurcation next to the baroreceptors and will, in fact, affect the autonomic nervous system. Does not need any leads in the heart or inside the vasculature. So Can the stimulation of the baroreceptors address this imbalance we've been talking about in patients with heart failure that have increased sympathetic tone and decreased parasympathetic tone? Where it has been clearly shown in this patient population and other patients with refractory hypertension and other groups of patients that the use of carotid sinus stimulation can decrease sympathetic tone and in addition can increase parasympathetic tone in this patient population. Ultimately, if we are able to reverse the effect of this that occurs during heart failure with sympathetic and parasympathetic tones, can we ultimately improve the symptoms these patients have associated with heart failure? And to be able to better understand this, a prospective trial called BEAT-HF was undertaken in the United States with full randomization of patients with optimal medical therapy compared to the Barostim device with carotid sinus stimulation and best medical therapy. Ultimately, this trial, after follow-up of this patient population, led to the FDA approval of this device in August of 2019, and we have gained a lot more insight on the results of using these devices as follow-up of these patients have continued, really up to now. What improvements that we have and we have seen, even at 6 months, fairly early in the management of these patients were noted to have significant improvements in exercise capacity, their quality of life, and an improvement in New York Heart Classification in at least a third of the patients, if not more, in this trial. Additionally, this kind of therapy was clinically relevant and super response rates were noted in the majority of these patients, and these were similar to those seen with CRT in CRT indicated patients. Keep in mind that CRT is only applicable to around a third of patients with heart failure, and this kind of technology may be applicable to the remaining patients with similar potential improvement in their heart failure symptoms. If we look at serious cardiovascular events in this trial and in this patient population, Barostim utilization significantly reduced the number of complications, had a relative reduction of 50% or more on cardiac arrhythmias, cardiac arrest, myocardial infarctions and angina, and hypotension and syncope, with a relative reduction of these complications of slightly over 50% in this challenging patient population. It was noted that there was significant improvement in exercise capacity that was as good or even a little bit better than CRT therapy and clearly better than just medical therapy, and clearly improved heart failure symptoms by decreasing sympathetic tone and increasing parasympathetic tone. So which patients benefit from this kind of treatment? Patients with New York Heart Classifications 3 or 2 that have had recent history or New York Heart Classification 3 and on maximal medical therapy, patients with low ejection fractions, usually less than 35%, those with a BNP of less than 1,600, and that population of patients that do not benefit from CRT therapy. In addition, those patients that have an ICD patients with exercise limitations, as we said, CRT non-responders, that increases the number of patients that may benefit from this therapy, patients that have recurrent hospitalization for CHF symptoms, and those that still have persistent symptoms and difficulties on many of the activities of daily living. So what is this procedure about? It's relatively simple nowadays. When we started doing this, it required implantation of leads on both carotid sinuses, and we learned that just by having one of them, there was more than enough effect for the patients to have significant benefit. So usually you have a small incision in the neck over the carotid bifurcation, have exposure of the carotid bifurcation, and then place a lead right at that location, and it's tested to make sure you have the desired effect. We look for drop in blood pressure immediately while the procedure is being performed. A lead is tunneled to a pocket, very much like for a pacemaker, is connected to the implantable pulse generator, which is placed in the pocket. The incisions are closed, And these procedures can be done being an outpatient basis or less than 23-hour admissions if you want to observe the patient overnight for any questions. So it's relatively simple, and a growing of patients benefit from this type of procedure. So in conclusion, an implantable carotid sinus stimulator, or Barostim, that provides baroreflex activation therapy safe and easy to implant nowadays with the device have significantly improved, is clearly indicated for a growing number of patients that need treatment for heart failure with reduced ejection fraction, which is the majority of patients with heart failure. And we have noted that potentially can be useful also for the treatment of patients with resistant and uncontrolled hypertension, even though in the United States it's not approved for that indication. It is outside of the United States and commonly used in Europe for that indication also. Thank you very much.
Great. Thank you very much, Dr. Sanchez. I don't know. We're trying to get the program here. I guess that's the number one thing, is to have a busy heart failure center, because it's hard. The vascular surgeons aren't going to find those patients, right? So I think that's probably the number one key to build
Correct.
that program.
I think you do need to have a significant heart failure program and cardiologists that have seen that this may benefit their patient among the other therapies that are currently available.
What are the other ones? What are the other competing therapies? I think we're doing CRT right now here, right? So, but is that,
yeah, for most of the patients,
population overlap, or is there one that's more for this, or?
There's some overlap in that patient, especially CRT is usually tried initially for a significant number of the patients. Plus, many of them, if they have a low ejection fraction, they get an AICD implanted for potentials to avoid, ventricular tachycardias or ventricular fibrillation if an event like that happens. If they failed CRT, or patients that have still persistent symptoms, despite that protective and additional therapy that they have, can benefit from this. So we're seeing more and more patients that already have one device. They have a variety of symptoms associated with their heart failure that are not responsive with medications or CRT therapy, and then they're being considered more and more for something like this. And now that it's less invasive, associated with limited complication for the implantation of the device, I think it's becoming more and more attractive.
What complication have you seen? I guess bleeding, right? What's the big
thing? Well, bleeding, one of the issues on the initial trial, since it was implanted in both carotids, it was the increased risk of potential nerve injury, very much like carotid endarterectomy. Now that it's a very small implantable lead, before it was much larger that required to be implanted around the whole carotid bifurcation, now the less dissection in the area really has diminished the risk of nerve injury and makes it a lot more attractive as an implantable device.
Excellent. I have to get on our cardiologists again. And that's my last one. What percentage of heart failure patients do you think are, I mean, if you had the criteria of New York Heart Failure 3 and 35%?
Yeah.
I mean, I guess so those are the main things. So what percentage of heart failure patients have that? Like,
I think if
we have two heart failure cardiologists here, you must have some patients. I don't know.
They must have. I would say that 20-30% of their patient population would be reasonable and could be considered for this therapy. But I think as they increase the patient population they treat, they may find more of those patients that are still persistently symptomatic and may benefit.
Awesome. Thank you so much, Dr. Sanchez. I look forward to seeing you in Chicago.
Thank you. See you in Chicago. Looking forward to the meeting.
Thank you to all the speakers. And just one last plug. So it's September 17th. It's on Friday. There's going to be a session in the morning for the APPs, which has already been programmed on a lot of the themes we've talked about tonight with different topics.
13th.
Huh?
September 13th.
What did I say?
17th.
Why? Thank God you're here. Yeah, September 13th, Friday. And then, so the morning will be for the APPs. There'll be two topics on medications and pharmacology, since some of the APPs need that for their CMEs. CMEs are possible through the Midwest Vascular. And then the afternoon, there's going to be a whole session of debates and other topics that will be of interest. So thank you so much. Thank you, Angela, for all your help getting this organized. Thank you to all the speakers. And we look forward to seeing you in Chicago on September 13th in the Westin Hotel in Chicago. Take care.
Thank you.